Good night, everybody. It's 8:06, and at this point we are not. So let's wait a little bit, please, until 8:10. Okay, 4 minutes more, and then we start. Okay, everybody, I'm sorry. I was with a patient now, but well, everything is done. So let's start, okay? 8 and 20, we have 1 hour, 1 class hour. Can you hear me clearly?
Yes.
Okay, perfect. Okay, let's go ahead. Tonight, we have the general view about the nervous system, mental illness, some details about blood, and some specific details about oncology. As you know, the general ways to take in account these topics and how to arrive so many situations, okay? Let's start with the nervous system. Of course, we all know we checked the left and the right brain with all the general information, the creative way, the right one, and the left one, the analytic way. So we all know about it. This slide is showing us some vocabulary to maybe define, to control this idea, to take some important information just. As anatomical review, taking into account the general view of this, not going into extremely small detail, we consider these slides, the anterior view of the brain and brain stem with the hemispheres, considering the right cerebral hemisphere, the left one, the cerebellum, the brain stem, and the spinal cord. Then we have the neuron anatomy, of course, as homework for checking all the vocabulary and specific details, how to write it down, how to name, to label every small part, we can say. And according to that, we have the chance to take into account this information and talk properly about these structures, for example, neurotransmitters, the dendrites, the synaptic vesicles, well, details like that we always have sometimes a little bit details to be clear on this. This slide is just for information, for taking into account that here we have a specific vocabulary. We are talking about the ECA, the AZ, and the SAM, the afferent neuron, connective neurons, and efferent neurons. With all of this information, we have the chance to understand how information goes through our body and how it's possible to feel about the SAM, the sensory neurons, associative neurons, and motor neurons. We have the functions of this, the types and the functions. Considering all of this, it's easier to catch how it works, we could say. Again, our anatomical review in the big schematic chart, when we have all the peripheral nerves and the central nervous system, considering it as specific names about the biggest branches. So taking in account, prepare on this, read this, and well, let's keep on working in order to prepare this information and of course memorize how to do this. Now we have a cross section showing the brain, the meninges, and the cerebrospinal fluid, and well, in purple now. Just check this schematic picture, considering the biggest details, as I was telling you, not so small, not so specific. We're not making it a mess. It's too much information just for considering it not be a bigger presentation. Now this cross-section about the major parts of brain. Well, we all know about it, but just making a review, preparing, and as you can see, we have lots of slides that look like similar, but making a comparison, they don't go in the same way. These brain parts and functions, it's again an informative slide, information here for catching the vocabulary that we really need. We must memorize. Read this, consider all of this, and according to this information, it's going to be easy to catch the meanings properly. Again, we have self-study slide with the cranial nerves for checking all the vocabulary and the, of course, functions and kind of peripheral or cranial nerve that it is. In that way, let's keep on working and practicing. And now we have this slide. Again, it's just for information, but it's going to be useful. The difference between dermatome and myotome. Well, when we are taking into account how they work, how the group of muscles or the region of the skin they are innervated, well, details like that, okay? I need one volunteer, please, for reading this chart, dermatome versus myotome.
May I?
Yes, of course. Go ahead. Thank you.
Just the blue one or both?
No, they're both, the blue and the green one. Making the comparison.
Dermatome versus myotome. A dermatome refers to an area of the skin innervated by the nerves from a single spinal root. A myotome refers to a group of muscles innervated by the nerves of a single spinal root. A dermatome is a region of the skin innervated by a single spinal nerve. Also, some consist of overlapping regions innervated by more than one spinal nerve and responsible for the coordination of senses. In the myotome, a group of muscles innervated by a single spinal nerve. Some are innervated by more than one spinal nerve, responsible for the coordination of voluntary muscular movements.
Okay, thank you. Okay, can you hear me clearly?
Yes, it's clearly.
It's clearly, it's right, it's correct. Okay. I'm asking for because someone is not in the possible to hear me properly, maybe. But we're patient. Let's work on this. When we consider the dermatome versus the myotome, we must check this slide, this picture. When we have the chance to check how they work, how they are innervated, so we can make a comparison in anatomical terms, and it's easier to catch its functions. And of course, the functions, as Andrea was reading, are so clear. So prepare on this, practice on this, catch this vocabulary. Here we have more anatomical review, considering now the cord plexus. And according to the vertebrae, they are easy to understand. We all know this from medical school. So let's practice on this. Check this, just maybe information, but it's useful, the vocabulary that is shown. Now the central nervous system and the peripheral nervous system with the parasympathetic and sympathetic nerves, considering all these functions. Check on this. It's a lot of information, I know, but we have to prepare on this. Now we have the overview, the chart that is showing us our details. Well, about the brain, the related combining form, cerebro or encephalo. The spinal cord, myel or myelo, and about nerves, neuri or neuro, as a general view of them. About sensory organs and receptors, we have the 5 senses that are just here for information, extra information, okay? The primary functions, of course, as we were talking in the previous presentations, are for reading at home, for catching the specific vocabulary. Talking about the word parts, in this presentation, we have the word root, for example, cause, cerebro, concuss, contuse, encephalo, or the suffixes, for example, stasha or graphy. Practice on this. So check the meanings, memorize them, because from these words it's going to be easier to construct or to catch the meaning from the anatomical terms. For example, with phobia, psych or psycho, radicule, radiculo, tropic. Practice on this. Going into this matter. The tendon reflexes. The examination of nervous system normally includes testing the deep tendon reflexes. For example, the knee jerks or the tendon hammer. That is also known as a reflex hammer, the reflex hammer, and now the knee jerks. That's the nice way to talk about the knee reflexes, the knee jerks, okay? We know that when we evaluate the reflexes by this maneuver, we must classify in how they are working on. And we had the chance to talk on this. The reflexes may be absent. The score is 0, so diminished, normal, 1+, or brisk, 3+. The plantar reflexes are also checked. The normal plantar response is downgoing movement, the plantar flexion of the big toe, and upgoing toes extensor of Babinski response is abnormal. We know about it, right? Going to chart, we have the chance. I will have the chance to make these grades from non-response to 0, going up 1, 2, 3, and 4. With 1, somewhat diminished, low normal. Number 2 plus, average, expected response or normal. With 3 plus, brisker than average, slightly hyperreflexive. And 4 is very brisk, hyperactive with clonus. We all had the chance to evaluate clonus, I think, during the medical school, but if we didn't, or we are still practicing as students, we stimulate the myotome, and then we can watch how the muscles start contracting so fast for a short period of time. This is the clonus, a local contraction that is followed by after the maneuver with the hammer. Okay. In this chart, just for information, we are showing the deep tendon reflex. For example, the biceps, the muscle that is evolved, the biceps again, the nerve supply, the musculocutaneous, and the root supply from nervous, the C5 and C6. This is just for information, for catching how the reflexes are going through our body, and to consider that this route, this way that information goes through our body is not going to change. They're following on a specific channel, we can say, on a specific origin. So from this information, it could be easier to understand these functions, for example. Talking about the motor system, we have the normal muscle and the atrophied muscle. So the examination of the motor system should include assessment of the following: muscle bulk, the amount of muscle tissue, the body, and we have to look for signs of wasting, or muscle atrophy, right? For doing this evaluation, we consider again the muscle tone. The muscle tone is the amount of tension in a muscle when it is relaxed. We have a tone that can be increased in spasticity or decreased in flaccidity. Or as the slide says, the active muscle and the inactive muscle. Check the difference and how it works, right? Now I have the muscle power, of course, the strength that we can use by our muscle system, following with the nervous system. This strength is, of course, related to the amount of muscle, to the muscle tone. That's why we are taking this in account. Then we have the coordination. This is the ability to use several muscles at the same time to perform complex actions or activities. For example, gait, the manner of walking, or any other reflexes while movement. Or like this patient that is making combining movements in order to perform this activity. For example, he's developing the eye and hand coordination. We really need to get on practice on this, the brain gyms, right? In that way, nowadays we have the idea that we must improve our brain gym for not losing functions. Elderlies have the chance to look for training like this and improve their brain skills. They are preparing in contralateral actions, ipsilateral functions, or as he is doing the eye and hand coordination and eye and feet coordination. Small actions make a great difference for brain. Talking about involuntary movements, we must consider this. we have these common types, the tremors, the myoclonus, tardive dyskinesia, the tics, and the atetosis. There's a very small video that I'm pushing play a lot for checking the movement, but that's the idea, just for catching the meaning of these words. Now I have this difference between spasm versus twitch. Maybe a volunteer for reading this chart? Someone who would like to read this?
I can.
Okay, perfect. Go ahead, please.
Okay, spasm. Muscle spasm is a long contraction resulting in a chronic pain. Twitch. Muscle twitch is the definition, sorry.
Yeah.
It's a short contraction resulting in mild pain and can be seen below the skin. A contraction in spasms is long and persistent, and contraction in twitch is short and mild. And the pain in spasms is greater pain in comparison to a twitch, and the pain in twitch is relatively less.
Perfect. Thank you so much, Melissa. So you can see the differences. For example, twitch in colloquial words, in Caribbean environment, I said, it's called gato. Have you ever watch a cat and the cat is relaxed without taking into account the environment, maybe sleepy? You go and touch his back and they perform a very short movement in back, like trying to get away. That's a twitch. The spasm, for example, when you get too much activity and then you stop suddenly and the muscle gets short suddenly and it's very painful, and sometimes you need a massage or pain relievers to help this structure. That's a spasm. Twitch, as Melissa was reading, is short and mild, not so painful. We all had the chance to have both of them. So practice on this, and if there's a question about the difference, tomorrow we can get more ideas to make a definition of this, the difference of this. Okay, let's talk about the case report. I mean, how to start the physical exam, the on-examination. When we receive a patient, we have the chance to make the inspection, to check all the situation in the first view, and then catch the important information we take into account, we consider for our purposes. When we talk about the examination, we must describe the situation, right? In this case, we are talking about a neurological situation, and we said on examination, her face showed little or no expression. There was a tremor affecting mainly her right hand. She had generally increased muscle tone. Power reflexes, coordination, and sensation were within normal limits. Examination of her gait showed that she was slow to start walking and had difficulty stopping and turning. Check the words in black that are in blacks in order to practice to catch the specific vocabulary to describe this kind of situations. But moreover, check here that we are talking again in past, and we are describing in medical terms. We are making this description in that properly way. At this point, in this example, we are not using abbreviations, but it could be better if we try to write down with them. Tomorrow we are going to start practicing on the physical exam, okay? When we talk about the motor loss, we have to consider this. The motor loss symptoms and signs include weakness, the loss of power, like this, yeah. The paralysis, the complete loss of power, the tremor, involuntary rhythmic movement, especially of the hands, most commonplace on hands, and the abnormal gait, unusual manner of walking. We have lots of weights, for example, the step gait or the horse gait, or details like that, in order to check these differences and infer the result of this, infer what pathology is related about. Talking about the speech, it might be also affected. For example, with hoarseness, that it's a rogue, deep voice as in vocal cord paralysis. Or slurred speech means pure articulation as in cerebellar disease. So hoarseness and slurred speech are the expressions we must memorize in order to follow our proper vocabulary. When we talk about aphasia, we consider all of these situations. The trouble speaking clearly, the trouble understanding speech, the trouble writing clearly, or maybe trouble understanding written words. Or maybe you have the chance to check the trouble about remembering words, or the trouble remembering object names, the common objects, I mean, the routine objects into our daily life. This is an extra slide just for information, just for catching the way we can use these expressions and some details for improving vocabulary. It's about the Parkinson's disease and the motor and non-motor symptoms. Considering this information, check details like this, like facial expression, or postural instability, tendency to be unstable, to place vertically, or maybe the loss of sense of smell, the mood disorder, and details like that. Just read this, catch the information, catch the specific vocabulary, okay? When we consider the sensory loss, we have to take into account the hearing. Well, the function is hearing. The loss is the deafness, and other symptoms that could be related to this. Buzzing or ringing in the ears, the tinnitus. You can see the buzzing or ringing in the ear is the colloquial way, the way that the patient uses an expression, the non-medical patients, I mean. On the other hand, we have the sight. The loss is blindness, and other symptoms that are related to this could be double vision, the diplopia, and blurring, loss of visual acuity, clarity of vision. So you can see. That's why we were talking about the blurry vision. You remember that? It's about this. About the sensation, the feeling. We can talk about numbness, the anesthesia, and then we have this other symptoms, the tingling or pain, pins and needles, the paresthesia. Then we have the balance. We talk about the unsteadiness, the ataxia, when we talk about the loss, and other symptoms, the dizziness or vertigo, right? So let's take this information in account. Let's practice on this because we need to well, we can say we need to memorize the common way to express this idea, how it gets translated and the meaning, okay? There are no common words of loss or conditions relating to taste and smell. So we only put the same expressions. About the syndromes of sensory loss, we have all of this chart to check the information. It's just extra information for reaching the specific vocabulary. And now let's talk. I'm sorry. Let's talk about a very important situation, the loss of consciousness. When we talk about the loss of consciousness, we consider this, how the patient is describing the situation, how the patient is taking into account its own moment and how they feel in that way. Patients may describe a sudden loss of consciousness in a number of ways. I mean, when they don't have any idea what's going on, or it's the first time this loss happens, or when they had the knowledge about a condition they are suffering or living with. When they talk about something that it's new, patients can say, I passed out, I had a blackout, I fainted. When they know about the condition, disease, or any other situation maybe, but they know that it could happen, usually patient says, I had a fit, I had a seizure, I had a convulsion. So fit, seizure, and convulsion are synonyms that are used to refer a violent involuntary movements, as in epilepsy. We as doctors may say, when did you lose consciousness? Right, so you have the chance to check the expression of the doctor, to check the specific way to ask about it, and the two possibilities of getting the answer. When patients are not sure, it's the first time they don't know if they have a specific diagnosis, and when they have the knowledge about its condition, right? This is a slide where I'm showing you the principal differential diagnosis between an epileptic fit and syncopal attack or fainting. We all know that both of them are not the same. We all know the difference is so extremely big. It's huge. Please read all of this. And tomorrow we're going to talk about this vocabulary. Check this information, practice on this slide. And in detail, we can talk by WhatsApp, okay? Check in some specific information, info cards, maybe we have the background about the sudden loss of consciousness that could be caused by a certain triggers. For example, the result of temporary decreased blood flow supply of the brain, or the prodrome usually associated with triggering event. I mean, a triggering event could be a concert when you have that big stimulus in lights, too many lights, and you don't have the medical, and you have a medical condition that is not letting you to enjoy these activities. About the prodromes, the most common ones are dizziness, lightheadedness, sense of being warm or cold, pallor, nausea, sweating, palpitations, the blurry vision, and hearing changes. So let's consider this in more specific vocabulary to check and be prepared with. About the pathophysiology, well, just for considering that extra information for catching the vocabulary, and That's a very good schematic information for reaching our vocabulary. About the causes of syncope, we have these acronyms, CONSNAC. So read all of this just for showing you how it works, how to direct our medical criteria, just for practicing, okay? Let's talk about coma. When we consider coma, of course, it's an unconsciousness with a reduced response to external stimuli. This state could be evaluated like this. We as a doctors could say the patient is in a coma or the patient is comatose. So we have these two ways to talk about it. It's easy, I mean, just as extra information, the Glasgow Coma Scale, I mean, we all have the chance to know about it, to get this in practice and consider this information. Very basic, and we all have the chance to work on this. The eye-opening, verbal response, motor response, and the meaning of each score we can receive. Well, this is the trauma and coma data bank criteria. In order to classify how the intracranial situation could be read. And they are talking about the CT scan and preparing some promediums. Extra information just for reading, for catching vocabulary. Again, extra information for considering the causes of loss of consciousness. We have the normal consciousness here as a schematic review. We have the vegetative state. We have the lock-in syndrome. And we have the brainstem death. In this slide, that is just added for bringing you some specific vocabulary. Consider the full situation, okay? Consider all the details that are just here in order to get an idea what we are talking about. And yes, our chart about pathologies. Let's consider the head and meninges, the disorders of the brain, neurodegenerative diseases, brain injuries, and the level of consciousness. According to this, we got some specific med terms and some ways to write it down. For example, we have the hydrocephalus, we have the Reye's syndrome, the Huntington's disease, the traumatic brain injury that could be a coup, a quarter coup, a counterblow, and shaken baby syndrome. Okay, then we have the levels of consciousness. When we say conscious, unconscious, lethargy, stupor, syncope, coma, persistent vegetative state, and the delirium. Now we have about the brain tumors. For example, we got the intracranial pressure, the strokes and cerebrovascular accidents, lots of them, the sleep disorders, the spinal cord injuries or disorders, the nerves, specifically peripheral nerves. We have the pinched nerves, the cerebral palsy, epilepsy and seizures, abnormal sensations, general neurology. Yeah, it's a very common situation. We all know about it. About abbreviations, as I told you last week, these charts are showing us the common abbreviations that are related into the hospitality environment, maybe from the place we are checking the information. But during homework, I'm sending lists of meanings of abbreviations, in fact. So considering this information, let's prepare. Let's practice on this. And well, for final test, I'm going to use the homework files to get in my opinion, the most common abbreviations. So keep on reading and practicing them, okay? Let's go with mental illness. Nowadays, very popular topic in our world, in general view, of course, because we all say that we might be prepared to attend, to assist our mental illness. We might be clear that we have the depression, the panic disorder, the schizophrenia, the phobias, the post-traumatic disorder, stress disorder, I'm sorry, the bipolar disorder, and dementia. All of these causes are followed by research that is supporting its place of everyone. And well, we have to be clear how to help our patients on these situations. Some common signs of mental illnesses: aberrant or sleeping changes, extreme mood swings, chronic low-grade depression, hallucinations and or delusions, unhealthy coping mechanisms, unusual emotional outbursts. So sometimes we don't have enough time to check our patients and take into account all of these signs. But in other situations, maybe we have the chance to receive a patient like this, and we must be prepared to recognize all of these signs. About psychiatric disorders, well, we must consider this, that a psychiatric disorder can be divided into organic or functional disorder. For example, dementia is a mental disorder due to organic brain disease. It's not because the patient wants, right? The commonest form of dementia is that associated with old age, the senile dementia. We all know how knowledge about it. And disorders in which there is no involved obvious pathology or anatomical change in an organ are determined as functional, the functional mental disorders. Talking about dementia, we have all of these symptoms and signs. When they realize that there are changes in memory, in perception, reasoning, attention, or concentration. On the other hand, we have the next steps that are not so clear for the patient, but they can be affected on thinking, on judgment, and language. And according to this, well, following all of this study protocol or dementia, you can find more patients than we really expect in community. Well, we have now the difference between psychiatric disorders and neurological disorders. All of them have an origin, of course, and all of them have a way to be treated. For example, in the psychiatric disorder, we can say that this is a substantial sharing of common variant risk. And you have all of these common situations. For example, anxiety disorders, bipolar disorders, anorexia nervosa, the ADHD, very common now, the Tourette syndrome, OCD, MDD, SED, PTSD, post-traumatic stress disorder. We were checking this in previous slides. The negligible sharing of common variant risks. We have all of these situations, but we have to be clear on this. The neurological disorders and are supported by organic changes maybe. And psychiatric disorders don't always have an answer. Okay. The difference between Alzheimer's and Lewy body dementia is just for information, for considering this and taking into account that it's very common to practice. And well, about the substance abuse. The abuse of substance means using it in a way that it's harmful. We all know about it. The commonest forms of substances abuse are alcoholism and drug abuse. I mean, with alcoholism, we lost control about how we consume these drinks. With drug abuse, well, we all know how it's drug abuse. So let's continue. No matter which one of these situations is happening, we got behavioral changes, and we have some signs and symptoms. All of these behavioral changes are checked through the time, not just in one view and one visit. Maybe relatives are not talking about it. So taking all of them, catching the specific way of this could be a great idea. So, for example, the secretive behavior or inflexibility with plans, or lying about plans, or financial troubles. Well, all of them are checked, as I was telling you, through the time, not just at the moment, or disregard of others, or slating. And about the substance abuse, we have the pure academic performance. For example, we have the drastic changes in weight. We have violent outbursts, excessive sleepiness. So take this information in account, catch this vocabulary, memorize, and maybe a situation that is going on could be easily treated or easily detected to start treatment. About affective disorders, this slide I'm showing you a slide with a book fragment when we check the difference between affect and mood. Maybe a volunteer for reading this slide. Someone who would like to do it? Hello.
Affect and mood are similar in meaning and refer to the emotions. For example, happiness or sadness. Affect tends to be used for temporary emotions and is expressed through manner of speaking, facial expression, or behavior. Mood is used to refer to a more permanent emotional state. The most common form of affective disorder is depression, the symptoms of which are poor appetite or significant weight loss, sleep disturbance, for example, insomnia, inability to sleep, fatigue, loss of energy, psychomotor agitation, excessive movement and thought, or psychomotor retardation, slowing of movement and thought, loss of interest in stimulating activities, decreased ability to think and concentrate, feeling that one is of no value to others or that one has done something wrong, recurrent thoughts of death or suicide. 5 or possibly 4 of the above symptoms occurring nearly every day for at least 2 weeks constitute a major depression.
Perfect. Thank you, Andrea. So you can see here we are checking some specific vocabulary that is giving us important information, maybe, and is helping us to recognize situations that can be prevented. In that order, when we realize our patient is in this situation, well, we take our hands, we make something, right? About types of mood disorders, we have bipolar disorder, seasonal affective disorder, chronic depressive disorder, anxiety disorder, psychotic depression, and the postpartum depression, right? Talking about the neurotic and stress-related disorders, we have the obsessive compulsive disorder as a good example. This is an obsession, an idea that is so persistent that it interferes with the patient's life. This is obsession, right? A compulsion is an obsessive idea that forces the patient to act, even though they recognize that it is unnecessary. A common form of this compulsion is washing hands every hour, every time, right? About the stress, it's a feeling of being unable to cope. It can lead to anxiety or fear of problems. A sudden attack of anxiety is called a panic attack. So you can see the definitions, the general idea of them. About symptoms and common signs of a neurosis, we consider them as extra information for catching the details how or when we are talking about it. Just extra information for practicing, okay? About the acute stress disorders symptoms, we have the intrusive, the dissociative, we have the avoidance, the negative mood, the arousal. Check the meaning of all of this, and then we have the post-traumatic stress disorder diagnosis criteria. All of these ideas are supporting this situation, and that's why we have to take it in count. Other types of functional disorders, they include behavioral syndromes associated with physiological disturbance, right? Such as eating disorders. For example, about the commonest eating disorder is anorexia, we all know about it, or bulimia, we all know about it. In this chart, we are talking about, well, in general, about an eating disorder, but for recognizing that maybe it would be happen, we take into account the excessive exercise, preoccupation of healing fat, abnormal electrolyte levels, intense fear gaining weight, the unusual large intake of food, the anxiety around or avoidance of eating. So we know maybe we had the chance to realize or to get in contact with a patient that was suffering this kind of disorder. About the disorders of all personality and behavior, or of course a personality disorder, we have all the Disney princesses. We might consider that they are cute, they are nice, of course they are. But when we have the criteria to check their behavior, their activities, we could see that something is going wrong. So just as extra information, maybe you would like to make research because it's supported by medical knowledge that they had a chance to believe, or they had the chance to act in a good way. But they didn't. They had many situations that they were suffering from. For example, Bella was the Stockholm syndrome. We all know about it. She fell in love with her captor. We have the Ariel, this lovely princess who decided to fall in love and change everything instead herself, for going back with a boy that just met once, or Jasmine that was in love with a thief, someone that was lying her all the time. Just as an extra information, don't take it personal, okay? About the mental retardation delayed mental development, well, we know that when we have something that is wrong with brain, we only have the chance to start therapy and go ahead in the best way as possible as it could be. And well, we just consider this as an extra slide for checking this detail. We need expert and authorities agree that mental retardation is a complex condition, of course, because treatment is not easy, and how to reach all the most or as much capabilities as we could is not an easy fact. Of course, mental retardation is a developmental disability, and mental retardation results in substantial limitations in 3 or more of the major activities of daily life. And mental retardation encompasses an heterogeneous group of people with varying needs of life and life context. So nobody of us is free about suffering this kind of situation in our kids now. So let's take it in count, just extra information, okay? Talking about schizophrenia as one of the biggest syndromes, biggest diseases, this disorder in which there are delusions, the false beliefs. We have the positives when we have delusions, hallucinations, and disorganized speech. Or we have the negative acting, the flattened affect, reduced speech, and lack of initiative. When we see someone that is fighting with these two situations, we never have to lose this person. About symptoms of schizophrenia in children, they are hardest, and they live with this bizarre behavior, flat affect, delusions, hallucinations, paucity of speech or thought, disorganized thinking, right? Okay, let's talk about blood. Yes. Talking about blood, we have this abbreviation FBC, and you might see this detail in previous slides when we were talking about lab tests and things like that. The full blood count, the FBC, the simplest test investigation of blood diseases. And FBC measures the following of a sample of blood. It means the FBC evaluates the amount of hemoglobin, the number of the different cells, or white cells, I mean, and red cells and platelets, the volume of the cells in general, and the erythrocyte sedimentation rate, measurement of how quickly red blood cells fall to the bottom of a sample of blood. So just for remembering this, for catching the abbreviations again and catching the meanings of any part of this. There is a chart with its own anatomical details, we could say. So study this, check the numbers, the percentages for practicing, and well, let's work. And now we have this anemia, the same as in Spanish, is the same in USA. But when you go to British English, you add an A and it says anemia. Yeah, it's anemia too. Pronunciation is the same. Of course, the meaning is not going to change. It's the same. Just taking account for the writing down way. This is the most common disease of the blood, and it may due to bleeding, excessive destruction of red cells, or low production for taking account. We have this vocabulary, this dialogue, when we have the chance to check some words in black. Please read this, practice on this, because we are almost out of time, but practice on this. And well, any detail, we can talk about it tomorrow. And we have this chart too, when we have these blackened words and we have the meanings about the specific details. So check the vocabulary, check the meaning for homework. And well, anything about it, it's going to be easy to be done. A grammar tip. We have the chance to use the verb reduce. And reduce have several meanings in medicine. Maybe to make it smaller. For example, we'd better reduce the dose of your tablets. Well, we have in surgery to return on anatomical position. An hernia can normally be reduced by manipulating. And we have in chemistry to reduce oxygen or add hydrogen. I mean, nitrous acid is a reducing and oxidizing agent. So you can see how we can combine this meaning and practice on this. Let's talk about oncology. Well, first of all is the meaning of neoplasm. It's an abnormal new growth of tissue. The malignant neoplasms are cancer are likely to spread and cause serious illness or death. And a benign neoplasm don't spread and are less harmful. We all know about this difference. While speaking to patients, we usually use these words, growth or tumor. Okay, not just tumor, growth or tumor, both of them are allowed. And we can say, you have a small growth in the bowel. Or maybe you have a small tumor in the bowel. Okay, don't forget growth or tumor. Talking about a lump or swelling, we all know it's a collection of tissue or fluid which is visible or palpable. Can be palpated or felt with the fingers. A lump may be due to a neoplasm, but there are other causes, such as inflammation or fluid accumulation. For example, patients come to us and tell us, I have a lump in my left breast. And the doctors usually say the description, I mean, there was a firm, palpable mass in the liver. So don't forget, it's the way to describe this. Firm, palpable mass, and the place it's located. Maybe a volunteer for reading this slide, different from Andrea. Okay. Is there a volunteer for reading?
Me. We have the results of the scan back now, and I am afraid they show that you have a small growth in the prostate. Fortunately, it appears to be at an early stage, and there is no sign of spread. So if we remove it, there is every chance of complete cure.
Thank you, Maria. Thank you so much. So you can see, when we talk about malignant tumors, they are characterized by the rapid growth and invasiveness. And when we realize when everything is done on time, without any delay, without any excuse, maybe with optimal conditions, we have the chance to talk with patients like this. But our reality is different, right? We can say the tumor may invade local tissues or may spread to distant parts of the body, the metastasis. Yes. We have the chance to consider that the neoplasm, which are the result of metastasis, are called secondaries, as opposed to the original tumor, which is the primary. You know, the original tumor primary, and all of the spreads are secondaries, right? When we say invade as a verb, it's to enter and spread throughout a part of the body. In this process is invasion as a noun. If a tumor is described as invasive, it has the ability to spread. Right, so let's check. That's not working. Well, this is a schematic explanation from the same text we were reading previously. Check on this, it's for you. And also, now we have symptoms and signs of malignancy about some specific tumors. Not all of them, of course, because it's too much, it's huge information, it's a lot of medical data to review. But we check this. The symptoms of malignant disease may be related to the size and location of the tumor, of course. For example, a space-occupying lesion in the brain causes raised intracranial pressure, and symptoms such as headache, vomiting, or visual disturbances. Tumors of the colon may be obstruct or block the lumen and cause change in bowel habit. Other possible symptoms of malignancy include bleeding, pain, and weight loss. So in this chart, we have these symptoms of metastasis again. We have in brain, headache, seizures, and vertigo commonly. The respiratory system, cough, hemoptysis, dyspnea. About the lymph nodes, we have the lymphadenopathy. About the liver, we have hepatomegaly and jaundice. About the skeletal system, we have pain, fractures, the spinal cord syndromes, and compressions, right? These slides are for taking information, for considering as a general view. We have the signs of brain cancer, the signs of symptoms of colon cancer. Read all of this. Tomorrow we can puntualize on more specific details or meanings, please. We are out of time. We had signs and symptoms of lung cancer and symptoms of breast cancer and the self-evaluation, right? So take it in count, read all of this, and we are going to solve. And now as a second case, we can talk about it. The breast cancer in male, non-common situation, but when it happens, it really needs a fast, very fast treatment. A 33-year-old man presented to his GP complaining of a painless lump on the right side of his neck, which has been present for about 2 months and was enlarging. He has been feeling generally unwell and had lost about 5 kilos in weight. He was also complaining of night sweats, and he had no significant past medical history. This is a good example about small resume of this kind of cases. Take in account the Black and words vocabulary, please. And when we talk about treatment of tumors, we have the chance to consider this specific vocabulary. A tumor can sometimes be completely removed or excised by surgery. If this is not possible, for example, if it has already metastasized or, to other parts of the body, it may be possible to destroy it by radiotherapy or by chemotherapy. When a cure is not possible, we use palliative treatment, which is only intended to relieve symptoms, okay? So check this slide for supporting, slow down, keep calm, be positive, take it easy, unplug, enjoy life, have fun, breathe, relax, go outside, meditate, and smile, always smile. I know it's a long, very long presentation, but we really need to be prepared on this. Let me share the pool to take attendance, and I'm going to upload these slides into the Zoom chat. Give me a minute, please, and I'm going to check your questions. Okay. Okay, medical English 5, it's here. Okay, as always, let me know that you got the slides. Okay, Maria, I'm gonna relaunch the pool for you. Give me a second, please. Okay, Maria, fill this. Fill again and send it again. Okay, thank you. Please let me know that you got the slides, always by a message. Don't, perfect. Okay, I'm closing the poll. Maria was the one who couldn't fill this. Oh, yeah, 17, okay. Okay, perfect. So in order you download the slides, you can leave the session, that's okay, no problem for me. And check if you can open this now, and according to that, we can solve all situations now. Okay, thanks for your attendance. See you tomorrow in the workshop.
Good night.
Good night, Andrea. Thank you. Okay, perfect. See you, Maria. See you tomorrow. Okay, Stacy, Misael, can you hear me?
Bye. Bye, doctor.
I'm going
Bye.
there. Yes.
Bye. Bye. See you tomorrow.
Good night, teacher.
Good night, Stacy. Have a great night. See you tomorrow.